Pulmonary Medicine, DNB, MRCP, MNAM. The degree is amazing. She's also a PhD. She is the Additional Chief Health Director in Medicine, in charge of Department of Pulmonology Medicine, postgraduate teacher, and of course, thesis guide for diplomate of National Board of Examinations since 2004, honorary faculty in Indian Institute of Medical Technology in Kolkata. And she also has, guys, National Award from Ministry of Railway India for contributing in the field of pulmonology, Zonal Award by General Manager Eastern Railways, and of course, also as a student. In fact, this amazing biodata only makes us very curious to actually hear from Dr. Das Gupta on the very interesting topic on immunopathology of asthma. So without much ado, Dr. Das Gupta, I hand over the session to you.
So thank you very much and for your kind words. Is it okay? Are we good?
Yes, Dr. Das Gupta, we can see it.
Okay, so at the outset, I thank the organizers, mainly Astra, for inviting me and asking me to talk on a topic which has been the central theme for most airway disease conferences, seminars that has been occurring in the past, I would say 10 years or so. So for the sake of simplicity, I have divided my talk today and I will be concentrating on the topic of immunopathology by way of describing phenotyping to endotyping, how to endotype and phenotype severe asthma, discuss different endotypes of airway inflammation. And I would like to do all of this in the perspective of a case study so that we can know the application of what we are doing today in our clinical practice. So what is severe asthma? I think most of us are comfortable with what severe asthma is these days. So asthma that requires following optimized guidelines suggested therapy to prevent from becoming uncontrolled, which means that when we are treating asthma patients, we usually do so by following the GINA guidelines in the step-ladder fashion. And when we have reached the step 5 and we do not know what else to do with our patients is what severe asthma is all about. It can also be defined by saying that asthma which requires treatment with high-dose ICS and a second controller for the previous year, or the patient requires systemic corticosteroids for 50% of the previous year to prevent it from becoming uncontrolled. So why is severe asthma so important? It's because of the healthcare costs that it involves. Only 10% of asthma patients have severe asthma, but the resources that we have to spend may cross as much as 50% resources or more. Okay, so coming to understanding severe asthma, what is endotyping, what is phenotyping? To take you through, I will first introduce a clinical case to you. So this is a case of a 50-year-old gentleman, a never smoker, asthmatic since the late 20s, has been having recurrent exacerbations, 3 in the previous year, short courses of corticosteroids. He admits to having allergy to dust, also has rhinosinusitis, nasal polyposis. Father had asthma. A 16-year-old son has just started to be breathless with exercise. And treatment-wise, he is on the highest dose of inhaled corticosteroids, long-acting beta-2 agonist, long-acting muscarinic agents, and also an leukotriene receptor antagonist. He had documented sputum eosinophilia once, and his specialist had decided to maintain him on a low dose of prednisolone, that is 7.5 milligrams daily. So this patient apparently has severe asthma because it fits to the definition of severe asthma. But then what are we supposed to do once we have reached the step 5? So this is when we need to know what the phenotype and what the endotype of asthma really is. So phenotype has been described as the integration of multiple observable characteristics of an organism which arise from the interaction of genetic and environmental influences, which means it's something which we can see in a patient. For example, if a patient has urticaria and a lot of itching, so that's a phenotype, allergic phenotype. So anything we can see is a phenotype, and A specific biological pathway is identified which explains the observable properties of a phenotype. Example, inflammation is the endotype. The example of this is that blood eosinophils, sputum eosinophils is something that we have to measure, identify, and advocate it as being the biological pathway in that certain patient. So phenotype is what we see, endotype is what leads to or what the pathway to that particular patient's manifestations. It's been very important in asthma management these days. Essentially, the endotype of asthma is 3 in count, but there can be overlaps in between as well. But for today, we are not going to go into the intricacies of the endotype of the inflammatory pathways of asthma. I'm going to be very, very simple and clear in what I say, because I do not want people to become complicated and complex descriptions. So when an allergen comes and hits the epithelium of the airways, a change happens, and we do not have that mentioned here. It's a damage-associated molecular pattern, which causes the dendritic cells to become activated. The allergen is taken up by the dendritic cells, which it presents to the naive T cells with the help of the T cell receptors. The naive T cell then differentiates into the Th2 type cell, which can again be of 3 main types based on the cytokines that are being secreted. Most of the cytokines that the Th2 secretes is the IL-5, which is the eosinophilic driven part of the endotypes of severe asthma. And the other arm of the cytokines that is secreted is the IL-4 and IL-13. These cause the B cells to become IgE secreting cells, which then attach to the mast cell with the receptors and cause degranulation of the mast cell and goblet cells, which result in the clinical manifestations of the asthma. So this type of asthma is called the allergic asthma because most of it is B cell driven. So the first endotype of inflammatory pathways of asthma is the allergic asthma. So the second endotype is the non-allergic eosinophilic asthma, which is what we shall be discussing in details today. Here again, the allergen comes in and activates the epithelial cells, which secrete alarmins, which are TSLP, IL-33, IL-25. These again, with the help of the dendritic cells, cause the differentiation of the naive T cells into Th2 cells. Now, Th2 cells are not necessarily present in just the blood. It is also present in the airways. So in the airways, it's called the innate lymphoid cells, and they behave almost like the Th2 cells, where they secrete the interleukin 5, 13, and 14 as well, 4 as well. So what IL-5 does is it attacks the bone marrow first, so that the differentiation and formation of the eosinophils in the bone marrow is increased. From the bone marrow, the cells are homed into the blood vessels. With the help of the blood vessels, they get home into the organ of damage, that's lungs. And once in the lungs, they are activated and degranulated, release a lot of cytokines and interleukins, which cause the damage in the airways that we can see in severe asthma. So this is the non-allergic eosinophilic asthma. This is the second phenotype or endotype severe asthma. The third endotype is the neutrophil-driven. What happens is more or less the similar way that happened in the other 2 endotypes. But in this one, instead of causing the differentiation of naive T cells into Th2 cells, what happens is the differentiation occurs in Th1 cells. And we see a lot of neutrophils there instead of the allergic eosinophils. So let me restate whatever I have been describing so far. So we have 3 endotypes of severe asthma mechanistically. The first one being allergic asthma, the second one being non-allergic eosinophilic asthma, third one being neutrophilic asthma. So I want you to remember these 3 endotypes so that when we talk about treating these patients, when we talk about biologics in the next talk, we'll be able to understand why and which biologic is actually effective in which phenotype of patients. So this is just a recapitulation of what I have just talked about. So TH high is not just TH2 high pathway. There are innate lymphoid cells which cause the inflammation as well in the organ of damage. In our case, it's the airways. So once we know that the endotype or the phenotype of the patient is either TH high or TH low, these are the things that we can expect from our patient's behavior. So a high TH2 is usually clinically severe, whereas the lower one may be less severe. TH2 high is more steroid responsive. The other one may be poorly steroid responsive. There is no eosinophilia in the TH2, whereas there is in TH1. Atopic IgE components present in the TH2 high, which is not so. In fact, it may be linked to obesity or neutrophilia. And the responsive to TH2 inhibition will be seen when all the other medications fail. So why are we so scared about the eosinophils in severe asthma? What happens? Like I have already described before, this is just a pictorial depiction. When the interleukins are secreted, especially the IL-5 in this case, it goes into the bone marrow through the blood vessels, and in the bone marrow, it increases the production of eosinophils by the bone marrow cells. From there, they migrate from the blood to the lung, which is called homing. Once in the lungs, they get activated and then degranulated to secrete these cytokines, cationic proteins, chemotactic peptides, lipid mediators, which are responsible for all the manifestations that we see in severe asthma. It causes remodeling, is something that we are all scared of. If the damage is permanent and not reversible, then we are in trouble. And it has been shown that increased baseline basal membrane thickness is more in case of eosinophilic asthma. Reduced epithelial cell integrity is again in danger in high eosinophils versus low eosinophilic asthma. And as well as the sputum eosinophil count correlates to something which has been described as the mucus score. A lot of the blood vessels get plugged by mucin, is what we have learned right from our MBBS days. And now it has been found that the mucus score correlates with the sputum eosinophils. And if there is a lot of mucus plugs in the airways, all the things which we do not want to happen in our patient does happen. For example, the FEV1 falls, exacerbation rates are high, the asthma control test or the exacerbations are also high, and anything which we are all scared of in asthma patients actually happen in patients who have more mucus secretion than the other patient who does not. So blood eosinophil can cause asthma exacerbations. It's more frequent exacerbations and poor asthma control in the patients who have a high eosinophil count versus those which are not. And we all know asthma exacerbations have been related to the way infarctions or coronary events affect the heart. So this is called the lung attack as opposed to the heart attack. So if you get a lung attack more frequently, the damage in the airways is likely to be more. And you must be wondering how would we know which patient is eosinophilic and which patient is not? There are ways of knowing. We can look for the eosinophil counts in the blood, tissue eosinophils, and at least one of them must be elevated to stamp the patient as having eosinophilic asthma. Okay, so understanding the accurate endotype is what clinicians are all interested in. And we can get it done by a number of methods, which I will be talking about shortly. Just to remind you so that we can apply our knowledge that we have gained into this patient, that our 50-year-old gentleman was a never smoker, asthma since late 20s, had recurrent exacerbations, was allergic, family history positive, was on very high dose of ICS, had documented sputum eosinophilia once, and was on very high dose of prednisolone, 75 milligrams per day, to keep his symptoms and under control. So When we look at this clinical picture, I think all of us are going to suspect that this patient has a allergic eosinophilic phenotype. Now, how do we understand, how do we know which patient has what type of asthma? What is the underlying mechanism? What is the underlying phenotype or endotype in this patient? So there are biomarkers available. So if it's an IgE-mediated allergic asthma, the blood IgE is going to be high. If it's going to be an eosinophilic asthma, which is driven mostly by IL-5, we can find blood or sputum eosinophilia. The FeNO may be raised, that's the fraction of exhaled nitric oxide. We'll talk about it a little bit more. And unfortunately, we do not have the technology of measuring blood interleukin-5 and periosteum as a day-to-day clinical practice. So the non-Th2 is neutrophilic, where the blood or sputum neutrophils can be high. And again, we do not have methods of testing for IL-18 in the market. So these two, Th17 and IL-8, is still a research tool. And when we talk about obesity and asthma, it's the lack of biomarkers that we're looking for, and not the blood, sputum, eosinophil, neutrophil, and all the rest. So FeNO is fraction of exhaled nitric oxide in asthma, and we have to interpret its results very carefully, because what FeNO does is that when its value is raised, it's just like interpreting an ADA report in pleural effusion fluids. If we have a raised ADA, it means that the patient has tuberculosis, but if the ADA is not raised, it does not mean that the patient does not have tuberculosis. So FeNO is right there. If it is elevated, inflammation is ongoing, is what we can say. We cannot say that whether or not that inflammation is eosinophilic or whether the inflammation is neutrophilic. So it's just that the patient has an ongoing inflammation, and the reason for that ongoing inflammation at best is to monitor the adherence. The patient may not be adhering to the prescription that you have already made for it. It should not be used for judging the response to anti-IL-5 therapies or any of the biologics for that matter. The only thing that we can say is about the adherence of the patient. So we have described more or less whatever the available tools are to understand the endotyping of the patients. So whenever I see a patient in my clinic who has a severe asthma, the way I try to sort out his immunopathology is by trying to imagine what mechanistic approach, what is the mechanism of the asthma in this patient. And the way I do it is, if I see a serum IgE or a skin prick test is positive, it means the patient has a B cell mechanism that is going on. And for that, we have all the other, therapies available, in addition to a biologic that we have been seeing for the past 20, I wouldn't say 20, maybe 15 years. That's omalizumab or anti-IgE. The second is the blood eosinophil count, which, if high, means it is a Th2-driven mechanism, and steroids is the answer to that. FeNO, like I said, means ongoing airway inflammation. And if we do not find blood eosinophil count, we might find eosinophils in the sputum. So sputum quantitative assay can differentiate between high T2 and low T2. So again, if eosinophils are present in the sputum, we know that it is eosinophilic asthma, and steroids are going to work. Now, this is data from my own lab. When we do an inflammatory endotyping by blood eosinophil counts, when the absolute eosinophil count is taken to be more than 300 cells per cubic millimeter. In my patient pool, I found that 64% patients were eosinophilic as compared to 36% which were non-eosinophilic. But when we did the same analysis in the same patient, sputum quantitative assay, the results showed that the eosinophilic number had gone down to 26%, whereas the neutrophilic had increased to 59%. Now, how do we explain this change? What happens is these patients are sometimes given a lot of inhaled corticosteroids, and we all know that steroids cause a reduction in the apoptosis of the neutrophils. So just because they are present in the cell in the sputum or in the blood, it doesn't mean that these cells are active. So we have to show or demonstrate that these patients have eosinophils which are active, and these patients are neutrophilic, they are not active. Okay, so one of the reasons for this discrepancy between the two experiments is that the patients with neutrophilic, with a lot of neutrophil in the blood, may not have a active neutrophil instead. And we've been noticing that there is absolutely no correlation between the sputum and the blood. So there is no deciding between whether or not you want a sputum versus a blood eosinophil counts or neutrophil counts or whatever. It's pretty clear from this graph that you can have a low eosinophil count in the blood and a high eosinophil blood in the count in the sputum, and vice versa. So it's all over the map. So there have been disadvantages in the sputum quantitative assay reports. The disadvantages being that sputum assay needs the wet lab, needs a trained personnel, and most of the tests need to be completed within 2 hours of collection of sample. Otherwise, we might end up losing the cells. And sometimes there is no sputum. You keep on measuring and trying the patient to expectorate, even if a little bit of sputum, but no, there is no sputum. So in this situation, we have tried to find out if the sputum fluid phase measurements are important proteins, which we can separate out from the cellular counts. So this is what we have found in our own study. We can see that there are inflammatory proteins which are raised in the frequent exacerbator patients, whereas they are not so in the non-exacerbators. And these names that you can see written below, azilocidin, neutrophil defensin, lactoferritin, and lysozyme, these are all neutrophilic proteins. So if these proteins can be identified in a clinical practice, then these proteins are the markers for inflammation and neutrophilic inflammation. Similarly, these proteins of oxidative stress and mucins were identified from the sputum fluid phase measurements. The measurements were mostly done by mass spec, a new method which is called SWOT. So this is from my own work. We have also found that there are lots of times when we do a total cell count, we see there are a lot of degenerated cells. It could be due to the procedural fallacies, or it could be due to the true degeneration of the cells. But if you do a total protein concentration in the fluid phase in these patients, there is quite a good correlation between the total protein concentration and the total sputum cellular counts. So this is something that we should be looking at whenever we think of AV research in the future. So coming back to our patient, we are now in a position to understand what the phenotype or the endotype is for this patient. Let's see what the investigation reports show. So pre-bronchodilator FEV1 was 1.6 liters, that's 62% predicted. FVC 3.2 liters, 78% predicted, the ratio being 50%. Post-bronchodilator FEV1 1.9, so a change of 300 ml and a FVC of 3.4. So this patient definitely has severe asthma, no doubt about that. Imaging-wise, HRCT is normal. The total IgE is 180, which is not that great. Absolute eosinophil count in the blood is 300 cells. So that's again borderline. So we went ahead and did the sputum quantitative assay, which showed a total cell count of 9 million, which is normal. Sputum has 60% neutrophils, which is normal. 10% eosinophil is abnormal, and an exhaled breath NO of 45. So exhaled breath NO is increased, and eosinophil is increased. The others are mostly non-contributory to what type of endotype or phenotype the patient really has. So again, recapitulation: serum IgE, B cell mechanism, blood eosinophil, T cell mechanism, Th2 mechanism, pheno, ongoing area inflammation, sputum assay, high Th2 versus low Th2. So what the investigation reports of our patient shows is that the total serum IgE was, again, like I said, was not that great. So from here, we can understand that the patient is going to need the sputum biomarker assay. And taking the investigation reports of the sputum quantitative assay from this slide, we know that the patient has an eosinophilic non-allergic asthma. IgE normal or slightly raised with a lot of eosinophils in the sputum gives us the endotype as being eosinophilic and non-allergic asthma. So now we know that this patient needs therapy with steroids and not antibiotics. So this is a very simplified 3-step diagnostic approach where we asked 3 questions in 3 steps to understand what type of inflammation or what type of phenotype or what type of endotype is going on in this patient. So is this asthma? If the bronchohyperresponsiveness is okay, then non-eosinophilic, non-allergic asthma. So there's no inflammation going on, so it's non-eosinophilic, non-allergic. Is this asthma eosinophilic? If yes, with a BHR, the patient is an eosinophilic non-allergic phenotype. And is this asthma allergic? If IgE is raised, if the patient is eosinophilic, and if the BHR is also there, present, then the patient has eosinophilic allergic asthma. Interestingly, let me summarize what I have talked about so far. Is severe asthma is heterogeneous. Knowledge of biomarkers and endotyping is required to prognosticate and predict specific treatment strategies when we are doing personalized medicine. Commonly used biomarkers are total and allergen-specific IgE, eosinophil counts in blood or sputum, and neutrophil counts. A mechanistic approach aids in accurate endotyping and adopting the correct treatment strategy, like I have demonstrated. And let me reiterate it. If B-cell mechanism, it's omalizumab that we are looking at. If the patient is not, patient's symptoms are not controlled despite the guideline-based therapy. If it's high Th2 type, it's the steroids. And if the steroids do not work, or you need a very high dose of steroids for the patient, we can go on to the anti-IL-5s. And lastly, if it's a neutrophilic mechanism, antibiotics and not steroids is what is going to benefit the patient. So this helps providing the right biologic to the right person. So this table more or less summarizes all the nitty-gritties of clinical phenotyping, endotyping, and what drug is going to be used in the patient. Thank you very much.
Well, thank you so much, Dr. Dasgupta. I think this was one of the crispest and taking us in detail what is endotyping, phenotyping, and how we can choose the right biologics to the right patients. There are questions. What we'll do is we'll take the questions in the last. And let me now introduce Dr. Rajesh. In fact, Dr. Rajesh, who's going to take us through Indian experience on biologics after the great session by Dr. Dasgupta on immunopathology, is going to take on Indian experience on biologics selection in the overlap patients. But before that, let me give you a small brief. Dr. Rajesh is currently working as a senior consultant and head of pulmonology department at Rajagiri Hospital, Kochi, and had his undergraduate training in Government Medical College, Kottayam. He did his MD in chest disease from GMC, Panji. Did pass out DNB in respiratory disease in 2005 and was a national level gold medalist. Amazing. He pursued critical care training in Apollo Hospital, Chennai, and is awarded diploma in critical care by the Indian Society of Critical Care Medicine in 2008. He's the recipient of Dr. Santosham Memorial Gold Medal in the national level in DNB Pulmonary Medicine in 2006. Now, during his postgraduate teaching career, spanning almost about 15 years, he has trained and guided many MD, DM, and DNB residents, and he's very popular, of course. And he's also a core organizer for all of us of conferences, CMEs, and pulmonologists, exemplified in NAPCON 2019. So I think without much ado, I hand over the session to Dr. Rajesh, who's going to take us through on Indian experiences on biologic selection in overlap patients. Over to you, sir.
Thank you, Anil. Thank you for those very kind words. In fact, I feel flattered. I hope I'm audible.
Yes, sir. Yes, sir. You're audible.
Yeah. Okay. So a very good evening to all the esteemed delegates. And at the outset, let me congratulate AstraZeneca team for joining hands with the Indian Chest Society and conducting this very relevant CME on biological agent use in asthma. And I would like to put upon record my sincere gratitude for allowing me to be a part of it. Asthma I think all of us would agree that it's one of the bread and butter diseases of the practicing pulmonologists. And although substantial proportion of asthma is easily diagnosed and treated, there is a small percentage that remains difficult to treat. It has to be remembered that small percentage of a huge number is still huge. So considering the huge burden of asthma in our country and the dense population of India, this small percentage actually translates to large numbers. And after a very systematic evaluation, these are the patients with severe asthma that might benefit from monoclonal antibody therapy. Now, till 3 years back, the clinicians had a very easy job.
Sir, sorry to
Yeah.
interrupt. Can you please project your screen, sir? We are not able to see.
Yeah, I'm not going to. I'm just giving a few words of introduction.
Sure.
Okay.
Please go ahead.
Yeah. So till around 3 years back, the clinicians had a very easy job when it comes to biological therapy because they had only one agent that was available in India. But the scenario has changed in the last 2-3 years with multiple agents available in the armamentarium. So phenotyping to determine the best agent is crucial upfront, and switching of agents has also become not that infrequent in the last couple of years. Coupled with this, there has been some Indian real world experience that has been mounting. So in the next 20 minutes or so, I will try to share with you all these things. So I'll just project my slides. I hope it's visible.
Yes, sir. You can put on the slide mode, sir.
I have actually put on the slide mode. Is it moving? It's not moving. Just a minute. Just stop sharing.
Yeah, now it is moving.
It's moving, but then it was not the full screen. 1 minute. Is it visible?
Yes, sir.
Full screen?
Yeah, it is not coming up to the full screen.
So you have to click the slideshow.
I have clicked the slideshow.
It's either at the top of the ribbon, you can see it says Home, Insert, Design, Animation, Slideshow. Or we could do
Animation.
it.
Dr. Rajesh, you can also click on the hourglass, which is there, no? Like we did when we in the start. Yeah, correct.
How is it now? Not really.
No.
We are able to see the slides, but not in the slide mode, sir, presentation.
You can see the slides though.
Shall we move in this mode?
Yeah, we can move in the mode in that. It's not a problem. Yeah.
Or else, sir, shall I project from my side? Because,
Yeah, only thing is you will have to just, keep on changing whenever I say.
yeah, absolutely fine, sir.
Okay, okay, then
so
go
I'll
ahead.
I'll just share my screen, sir. Just a
Okay.
So whether the screen is visible, sir?
Yeah, it
Yes,
is visible,
to me.
Naga.
Yeah. Shall I start off? Or you are going to full screen mode?
Yeah, I'm going to full screen mode, sir. Just a minute, sir.
Naga, or you can just do it in the same way. Not a problem.
No, just a minute. Just a minute. Yeah. I'm just sharing the screen. So So whether the screen is visible?
Yep.
Just a minute. Whether it's available in full screen?
It's not available in full screen.
Can you click on the R glass, Naga, or on the slideshow? Besides, yeah. That's it. Can you? Yeah. Okay.
Can you just make the slide a bit smaller? Yeah, that's it.
Whether it's visible now?
It's visible. Or Nagash, I think I will try to share with whatever is available, because it's yeah, now it's perfect. Now it's perfect. Yeah.
Is it okay, Anil, sir?
Yeah, it's fine.
Okay. So sorry for that small technical challenge. Naga, can we go to the second slide? Yeah. So what I would be trying to do in the next 20 minutes or so is to try to elucidate severe asthma and how exactly to place biological use in severe asthma. Then share some of the Indian experience with biologicals. The studies that I would be trying to share with you will be the artwork study, the biosimilar study, and the mepolizumab case series. These are the three things which I have just handpicked. And then the choice of agent when a patient presents to us with the overlapping severe asthma phenotypes, how to phenotype, and finally, as an agent, how does benralizumab fare, evidences for its rationale and superiority when it comes to treatment of severe asthma in overlapping phenotype. So shall we move to the next slide? Yeah. What is the choice of biological agent in an asthma patient with overlapping phenotypes? That's what first I'm trying to do. Next slide. Next slide. Yeah. So before jumping to the use of a biological, sorry. Yeah. Previous slide. Yeah. Before jumping onto the use of a biological agent in severe asthma, the basic things have to be done correctly. First of all, the diagnosis of asthma should be secured. Similar conditions which can have a similar clinical presentation like foreign body aspiration in children, COPD, bronchiectasis, airway tumors, etc. should be excluded by appropriate evaluations. Compliance to inhalers should be ensured. The inhaler technique should be supervised and the correct technique should be ensured. We should address comorbidities that can worsen asthma control like upper airway disease, GERD, thyroid disease, OSA, etc. We should administer the proper quanta of treatment. That is a high dose of ICS-LABA combination plus a LAMA plus a leukotriene receptor antagonist. And at least in Indian circumstances, we are very fond of a sustained release theophylline also. So administer the proper quanta of treatment. And if after this checklist, if the asthma is still remaining severe and uncontrolled, that is a scenario when we start thinking of a biological agent rather than upfront. Next slide. Yeah. So when we think of instituting a biological therapy in a severe asthma, first of all, we look at the phenotypic traits which make the patient suitable for a particular agent. So basically, there is an atopic asthma, there is an eosinophilic asthma, and there is a substantial overlap between these two phenotypes. And then there is the third type, neutrophilic asthma, which actually doesn't overlap and which actually is not amenable to treatment with any of the available biologicals in India right now. Next slide. The next slide. Okay. So what are the simple tools for phenotyping, which Dr. Angara had actually described a lot of details. So as a simple practicing clinician, what are the tools that are available to us in our day-to-day practice? The clinical history is very important. The age of onset of asthma symptoms, the family history, the history of allergy and all tell us that the patient is probably having an allergic phenotype. Blood parameters, including the CBC and the peripheral blood eosinophil count, the IgE levels and all are important for both the eosinophilic as well as the allergic subtype. The allergic subtype can be further substantiated by doing a skin prick test or a rash and demonstrating allergy to either a group of agents or specific agents. And induced sputum eosinophils can be used for conclusively making a diagnosis of eosinophilic phenotype combined with the FeNO levels, the FeNO levels that we usually test to demonstrate the presence of an eosinophilic airway inflammation. Next slide. So these are the rough guides of allergic versus non-allergic asthma phenotypes. The allergic phenotype has a young age of onset and it is clearly associated with allergic triggers. Seasonal variations in symptom pattern is very marked, whereas these things don't occur in the non-allergic phenotype. Food allergy is very common in the allergic phenotype, whereas nasal polyposis is much more common in the non-allergic phenotype. The family history is very important in allergic phenotype, and smoking history is very important in the non-atopic phenotype, because the non-atopic or the non-allergic phenotype is more associated with the smoking history and history of exposure to various environmental things. And abnormal lung function is more commonly seen when the patient is not in an exacerbation. The abnormal lung function is more commonly seen in the non-allergic asthma. The next slide. So these are the approved agents for biological treatment in severe asthma: omalizumab, mepolizumab, benralizumab, dupilumab, and restylizumab. Now we take two of these things out of the equation. That is, dupilumab and restylizumab are not available in India. And restylizumab probably may not be a very great option because it has the same pathway of same mechanism of action as mepolizumab and benralizumab. And in addition, it is used as an IV infusion. So even if it hits the road, I was a bit skeptical whether it will be of real benefit or it will have a real advantage over the existing ones, that is mepolizumab and benralizumab. So omalizumab is the one having the largest body of experience because it has been around for almost 15 years. The challenges with omalizumab is that it's a modest potent agent. The weight, the dose is actually variable depending upon the pre-treatment IgE levels and the weight of the patient. And the duration of administration, that is the frequency of administration, is also variable depending upon these factors. And it has a black box warning of anaphylaxis, which although there is a black box warning, we don't see very frequently in our day-to-day practice. Mepolizumab and benralizumab are the recent additions in the last couple of years to our armamentarium in India. Of this, they both have the advantage that they can be given as a simple subcutaneous injection, and it comes as a preloaded syringe. Vis-a-vis omalizumab, which actually has to be reconstituted, and the reconstitution process is slightly challenging for the busy practicing clinician. So the advantage of benralizumab over mepolizumab is that after the first 3 doses, which happen in a monthly fashion, the subsequent doses can be given once in 8 weeks, so once in 2 months. So that is a real advantage for the patient as well as the clinician. Whereas when it comes to mepolizumab, yes, it also is pretty easy to administer, but it has to be given once in every 4 weeks. Next slide. Next slide. So what are the guidelines available for selection of a particular biological agent in severe asthma? So here the guidelines actually recommend something known as the phenotypic biomarker and outcome model. Okay, we have to look at the phenotypic traits of the patient as to what is the most abnormal, most or rather most pronounced aspect of his phenotype, like exacerbations or lung function decline or comorbidities and all those things. And we have to use the biologicals for biomarkers for phenotyping, including the sputum and blood eosinophils, the FeNO levels, IgE, all those things. And much more important is that when it comes to biological treatment, there should be a shared decision making with the patient. So each patient is unique. He might have his own whims and fancies about what this treatment is going to fetch him. So the clinical evidence of benefits with that particular biological agent should match realistic expectations of the patient. So that is one very important factor that actually will determine which biological agent we should use. For example, if a severe asthma patient is on a very heavy dose of oral corticosteroids, and he has a troublesome symptom with oral corticosteroids like osteoporosis or bleeding ulcers and all those things, his priority would be somehow to get out of oral corticosteroid use. And here we know that all the 3 biologicals, there is omalizumab, benralizumab, as well as mepolizumab, have some oral corticosteroid sparing effect, but that effect is best with benralizumab, and it comes at a fastest pace with benralizumab. So if other parameters like the economic factors and other things are congenial, probably we would go ahead upfront with benralizumab with this particular patient. So these are some things that actually dictate the choice of biological agent. So it should be a shared decision making with the patient. And once we institute a particular biological agent, we have to observe the patient for around 3 to 6 months and see whether the expected outcomes are there for the patient. If not, then probably we should think of switching a biological if the patient has an overlapping phenotype, or if there is no other option, then to just stop biological agent treatment and look for other options like long-term microwave therapy or bronchial thermoplasty or something like that. Next slide. So again, this is the algorithm for biological therapy in selection in severe asthma. There are some of the comorbidities which actually make the patient more suitable for a particular biological agent. Like if the patient has significant nasal polyposis, of course, that is a feature of non-allergic asthma, but if the patient has an allergic phenotype with nasal polyposis, then they become very good candidates for omalizumab, asthma, and mepolizumab. Whereas the patient has atopic dermatitis with nasal polyposis, then dupilumab will be the best agent. Eosinophilic granulomatosis with polyangiitis. This is one indication where mepolizumab has actually been approved for treatment. So there are other comorbidities and other nuances which make the patient more suitable for a particular biological agent. Next slide. Next slide. Yeah. And there are some factors which make the patient more amenable to response with one particular biological agent. Now, if you see anti-IgE treatment with omalizumab, then a high FeNO level, a high blood eosinophilic level, significant allergic-driven symptoms, significant history of childhood onset asthma. These are some of the factors that make the patient a good response candidate for omalizumab. And if these factors are present, maybe we are tempted to go ahead with omalizumab as the upfront agent of therapy. Whereas when it comes to anti-interleukin 5 agent therapy, a higher blood eosinophil level pre-treatment, frequent exacerbations, high use of oral corticosteroids, adult onset of asthma, presence of nasal polyposis, etc., are some factors which make us tell that probably this patient is going to respond very well to an anti-interleukin 5 agent. So these are some of the aspects which actually decide or help us to decide the choice of agent upfront when it comes to an overlapping phenotype. The next slide. With this, I will rush through fast with some of the selected Indian experiences with biological agents in asthma. The next slide. Next slide. So I will just share 3 publications from India: the artwork study, the biosimilar study, and the mepolizumab case series. Next slide. The artwork study actually was done on omalizumab, and we had the privilege of publishing this particular study. The acronym artwork stands for Acceptance and Results of Therapy with Omalizumab in Real World Kerala Setting. It was actually published in the Journal of Asthma 2021. The next slide. Next slide. So this particular study was actually looking at 3 aspects: the attitude of patients towards offering of biologicals, then the results of therapy with omalizumab, and how the patients fared after discontinuation of omalizumab. These were the key factors that were studied in the artwork study. The data retrieval period spanned from January 2017 to December 2019. Uncontrolled asthmatics who were actually screened for all those comorbidities and all those things. So the true severe asthmatics were chosen. The data collected were acceptance to omalizumab therapy when it was suggested and put across to the patient, the level of asthma control while on omalizumab, the duration for which the patients took this treatment, and the control level after discontinuation of omalizumab. Next slide. The next study. Yeah. We had 560 patients with uncontrolled asthma, which was encountered in our severe asthma clinic during these 3 years. Now, out of this 480 patients had simple modifiable factors like non-compliance and lack of addressal of comorbidities and all. So when these modifiable factors were actually modified and addressed to, we were left with around 80 patients of the 560. So that means that hardly 10% or 10 to 15% of uncontrolled asthma patients had actually true severe asthma. Next slide. Now, the 80 patients with severe asthma, around 51 of them were actually suitable for omalizumab treatment, whereas 29 were not suitable for omalizumab treatment because they were not suitable based on body weight, IgE rate, or non-atopic nature of their asthma. The next slide. So the acceptance rate, if we see, of those 51 patients who were deemed suitable for omalizumab, we offered the drug for each and every patient. Now it was seen that just animate, just click. Naglan, just click once again. Yeah, once again. So out of this 51 patients, only 16 accepted to take omalizumab, whereas almost 35 of them chose not to take the drug. So why was this so? Go to the next slide. So a substantial chunk of patients, almost 46% of these 35 patients, had an erroneous feeling of good asthma control, despite their asthma being uncontrolled by our traditional GINA or whatever be the guidelines that we follow. So this was actually very clear in the AIM study, AIM Asia Pacific study by Dr. Salvi and all, where none of the Indian patients had actually guideline defined asthma control, but they were not much concerned about the guideline level asthma control. They were just concerned about reasonable control of symptoms. Cost factor was an hindrance in around 30% of patients, and some of them had injection phobia also. Next slide. So all the patients, all the 16 patients who had taken omalizumab had improvement in asthma. It was tested with the asthma control test, the exacerbation rate, and the mean daily systemic corticosteroid need in prednisolone equivalents. Next slide. So just animate, just click once again. Yeah. So there was a 4 to 5 point improvement in asthma control test that was actually persisting even after 6 months of treatment stoppage. Now, as I will come to in one of my subsequent slides, it was seen that only the duration of treatment was, mean duration of treatment was around 8 to 9 months only in all these 16 patients. There were only 2 or 3 patients who actually continued the treatment for more than 1 year. Next slide. Again. Yeah. So the exacerbation rate almost reduced to 1/5 with omalizumab therapy. The next one. Almost 50% of patients were off systemic steroids at 6 months. Now, this was something very, very, very unexpected from our study, because omalizumab traditionally the steroid sparing effect of omalizumab is not that great as compared to interleukin-5 treatment. The exacerbations rate definitely come down, but in our study it was seen that there was significant capability of omalizumab to actually come down on the mean steroid use and even ability to stop steroids in many of these patients. Next slide. And the mean systemic steroid dose was almost reduced to 1/3. The next slide. Again, the duration of therapy, that was very interesting. Of the 16 patients who took omalizumab, 14 patients wanted their clinician to allocate a fixed time period of therapy upfront. Even before starting therapy, they wanted the clinician to say that, okay, I'm going to give you a therapy for this month only. Okay. The mean duration of treatment was only 8 months, and 12 patients settled for 6 months. 2 patients continued beyond 1 year. The reason for stoppage also varied, but none of them actually stopped for lack of efficacy. Next slide. So subjective improvement was the reason that many of the patients stopped therapy. So they no longer felt that they needed an agent like this. So probably omalizumab was a victim of its own success. Economic factors were definitely a concern, and concern for long-term side effects also was one reason which made patients stop therapy at maybe 6 to 8 months. Next slide. Just go ahead. So I can just summarize that there were 560 patients. After evaluation, 51 of them had true severe asthma and qualified for omalizumab. Of this 51, only 35 patients took omalizumab. 16 patients took omalizumab and 35 patients opted out. The mean duration of therapy and asthma control was noted, and it was seen that the mean duration of therapy was only 8 months, and good asthma control was afforded by omalizumab therapy. The next slide. Next slide. So the key realizations from the artwork study was that step 5 asthma therapy is required only in around 10 to 15% of uncontrolled asthmatics. Most of them have otherwise modifiable factors. 2/3 of the patients who benefit from omalizumab therapy actually opt out of therapy for varying reasons. But whoever took it get excellent clinical benefits during and after treatment, and the mean duration of therapy with biologicals that these patients took was only for 6 to 8 months. Next slide. The common reasons for refusal were false perception of good asthma control and cost of therapy. Most patients were willing to take it for a finite time period only. The common reasons for discontinuation include good improvement of asthma and concern of adverse events. Next slide. Now this actually was an industry-sponsored trial conducted by Reliance, which actually looked at the innovator molecule of omalizumab, that is Xolair, versus the biosimilar, that is Emsumab. It was actually done in around 104 patients. 69 patients actually took Emsumab and 35 patients took Xolair. And the responders were actually looked at 16 weeks. And it was seen that, then let's go to the next slide. It was seen that there was good improvement in symptom control, the lung function, as well as good global evaluation of treatment effectiveness in the patients who actually took the biosimilar. And based on this, go to the next slide. So based on this, it was concluded that the biosimilar study, omalizumab and the reference product were comparable in its efficacy, safety, biosimilarity, and characterization, including immunogenicity. And there was no clinically meaningful difference between the biosimilar omalizumab and the innovative products. So based on this particular study, the biosimilar agent was approved for use in India, which actually comes under different trade names marketed by Reliance as well as Cipla. The next slide. Now, this is a case series on mepolizumab published by Dr. Nagarjuna and his team. This was actually done in 4 patients with severe eosinophilic asthma who actually required maintenance therapy with oral corticosteroids or were requiring frequent bursts of steroids. 2 of them had prior omalizumab treatment also. The next study, next slide. So it was seen that, just once again. So it was seen that there was a dramatic improvement in eosinophil count and ACT score with mepolizumab treatment. Click once again. And there was significant decrease in need for maintenance oral corticosteroids in these patients who were treated with mepolizumab. Next slide. So the key realizations from this case series was that mepolizumab affords very good clinical benefit in those eosinophilic asthma phenotypes. It is very useful in overlapping asthma phenotypes also. It is useful in cases where omalizumab therapy has failed, and it has most pronounced effect in eosinophil counts, but the asthma control level as well as steroid requirement, all of them come down. Go to the next slide. So this is actually a extrapolation of the global evidence to the Indian soil when it comes to mepolizumab therapy. The final part of my talk will be on the role of benralizumab in overlapping severe asthma phenotype and the rationale as well as evidence for its superiority. Go to the next slide. Now, this is actually data that is available in file with AstraZeneca based on the benralizumab patient access program. It actually is done in 5 large asthma centers in the UK with almost 220 patients. So the clinical outcomes after initiation of benralizumab therapy in severe asthmatic eosinophilic asthma patients were actually assessed with regard to the exacerbation rate, the oral corticosteroid use, and the patient-reported outcomes, including the asthma control questionnaire. Next slide. So it was seen that there was excellent benefit with benralizumab when it comes to exacerbations. There was almost an 80 to 85% reduction in acute exacerbations with benralizumab therapy. So that is a huge magnitude. If you see most of the biological agents, they decrease the exacerbations, but the magnitude of benefit that is afforded by benralizumab is pretty huge. And what is interesting is that this benefit of reduction in exacerbations occurs irrespective of the atopic status, whether the patient is atopic or non-atopic. If he has a eosinophilic asthma phenotype, they get benefit from benralizumab therapy. Next slide. The preliminary results say that the benralizumab reduces exacerbations, oral corticosteroid use, improves patient-reported outcomes regardless of the atopic status, and that too in a real-world setting, not in a very stringently controlled trial setting. So there is 85% reduction in exacerbations, 50% reduction in oral corticosteroid dependency, and patient-reported outcomes. Almost 60% of the patients have very good clinical outcomes. Next slide. So again, it was seen based on this study that it was seen that there is improvement in those patients who used benralizumab upfront, as well as patients who actually were switched from some other biological to benralizumab based on lack of efficacy. So whether the patient, if the patient has an eosinophilic asthma phenotype, whether he is treatment naive or whether some other therapy like mepolizumab or omalizumab has failed, a substantial chunk of them, almost 80% of them, actually respond very well with benralizumab therapy. The next slide. Yeah, and in fact, there was a small percentage of patients, around 22 patients, where these patients had almost, after 1 year of therapy with mepolizumab, they had inadequate clinical outcomes. So when these patients were actually switched on to benralizumab, it was seen that they had significantly improved clinical outcomes. So the moral of the story is that, eosinophilic asthma phenotype, treatment naive, previous biological agent use, atopic, non-atopic, doesn't matter. Benralizumab is a very good treatment option. The next slide. Yeah, there are case reports of 2 oral corticosteroid dependent patients with asthma who actually had persistent symptoms after 2 years of treatment. Therapy response with benralizumab. In fact, one of these patients had initial omalizumab and then mepolizumab, and finally had improvement with benralizumab. Next slide. Next slide. Yeah, I think again similar case reports are there. Go to the next slide. So again, there is this anti-study which actually confirm and extend the efficacy profile of benralizumab for patients with severe eosinophilic asthma with a eosinophil count of more than 150. Because traditionally, most of the studies and trials have looked at benralizumab efficacy when the peripheral blood eosinophilia is more than 300. Now, the anti-study has actually said that it's beneficial even if the peripheral blood eosinophil count is more than 150. Next slide. So, if I can just summarize what I told over the last 20 to 25 minutes. There is a small proportion of asthmatics who have real, true severe asthma, but this accounts for a very small percentage only, maybe 10 to 15% of asthma. But as I said previously, this translates to very large numbers because small percentage of an extremely huge population is still large. A substantial chunk of the severe asthmatics in India have an overlapping phenotype, overlapping allergic plus eosinophilic phenotype. So they become candidates for both anti-IgE as well as anti-interleukin 5 therapy. Now, there is some emerging evidence that probably anti-interleukin 5 therapy may be superior to anti-IgE therapy because it gives much more substantial benefits with regard to reduction in exacerbation frequency and reduction in the level of oral corticosteroids. And among the 2 interleukin 5, probably benralizumab is a much potent depleter of eosinophils and might translate to better clinical outcomes, especially in those patients who have failed with mepolizumab. The next slide. Thank you so much. Thank you for your patient listening. Thank you so much. And thanks, Nagarajan, for your help.
Thank you so much, Dr. Rajesh. In fact, I must tell you, as a brand manager for Fasenra, it's a music to my eyes when you said, it has an excellent results in exacerbation. Fasenra has an excellent result in OCS reduction in FEV1. Whether the patient is treatment naive, whether it is shift from mepoli or omali or atopic or non-atopic, Fasenra has an amazing result. And as the last part, it is the most hard hitting, Dr. Rajesh, when you said Benrali or Fasenra is most powerful. That got stuck in my mind. So thank you so much, Dr.
Anil, I was just sharing the published evidences that I can find.
Absolutely, I agree on that. So.
But then omalizumab is still close to my heart.
Yeah, we'll ensure that Fasenra is with the experience, Dr. Rajesh. I think that is once definitely we'll you'll have that experience and we'll also be closer to your heart. But yes, thank you so much, Dr. Rajesh and Dr. Dasgupta. I think it has been an amazing session. But quickly jumping to the question, we have one question coming up to you, Dr. Dasgupta, and that is from Dr. Matthew Varghese. The question is, sputum or blood eosinophil is more reliable? What is more reliable to document as eosinophilic asthma?
Okay, so like I said, you could measure eosinophils either in the blood or in the sputum. So which one is superior is what you want to know. When you judge, say, for example, if you want to know the blood cholesterol level, you would do the blood. You would not do an urine, right? So similarly, if you have to know about the lung airways, the inflammation that is going on inside the airways, we need to do a sputum assay versus a blood assay. So sputum is definitely more superior in terms of its accuracy in determining the endotype or whatever works for the patient as opposed to blood. But again, taking the feasibility factor into account, blood might be an option whenever we cannot do a sputum quantitative assay.
Great. Thank you so much, Dr. Dasgupta. I think there is another question coming up to you, Dr. Rajesh. The question is, please share landmark study data about the management of comorbidities in severe asthma via biologics.
It may be challenging for me to share the whole lot of studies, but then, as I showed in one of my slides, a patient with severe asthma, if he has allergic comorbidities or non-allergic comorbidities like nasal polyps, then he becomes an excellent candidate for dupilumab as well as mepolizumab. Atopic dermatitis, yes, very good candidate for dupilumab as well as mepolizumab. Patients with hypereosinophilic syndrome, eosinophilic granulomatosis, polyangiitis, we have mepolizumab that has been approved for these indications also. So there are landmark trials in each and every aspect of this. It becomes challenging for me to share each and every data in maybe 5 minutes, but probably what we can do is we can just see who has taken that question, who has shared that question, and we can probably take his email ID and share those landmark studies with him. That will be the easiest thing.
Yeah, it is Dr. C.K. Som. We can do that.
Yeah.
Okay, Dr. C.K. Som has also asked a question. Maybe both of you can answer. Please share your clinical experience about the prolonged effect of biologics post discontinuation of therapy.
I will just have 2 words on that. If you bluntly look at our artwork study, then it said that 6 to 12 months after discontinuation, there is still retained good benefit. But then that is not what the global data says. We have a head-to-head, we have a randomized trial of patients who stopped omalizumab at the end of 2 years versus who continued for a longer period of time, and said that those who continue omalizumab have much better outcomes as compared to those who discontinued. So the probable moral of the story is that if someone is improving and if he can afford, probably continue it for the long term. Maybe Madam also can add on that.
I agree completely with you, Dr. Rajesh. The only thing that I want to add is that when we see a patient of severe asthma in the clinic who is on biologic, what we can do is stop the biologic and see if the cells come back. So if the cells come back, it means that again, we have to give the biologic, if not controlled by steroids and the other guideline-based therapy. So the way I have been trained to do so in the inflammatory lab is that first, if you see the patient is having eosinophilia, despite having all the medications the guidelines have said, we try to come down on the dose of the steroids to see which is the dose which the patient is comfortable on. Having said that, means supposing we start with 30 milligrams per day, so we tell the patient to be a bit observant to see which is the dose with which he is comfortable in. And then at that stage, we do a blood or a sputum to see if the data matches, the reports match. And from there, we start introducing the biologic agent. And then further onwards, we start reducing the steroids further with the support of the biologic. I hope I could answer the question.
Thank you so much, Dr. Dasgupta. I think continuing to that, I think one more question to you, Dr. Dasgupta, where we have a question is blood EOS is very common in Indian patients. So how to pick up a right severe uncontrolled asthma patient beyond EOS phenotype?
Okay, so this again would be an emphasis on the sputum counts. So like I said, if you have a type of cell in the blood, it doesn't mean that it is working, it is activated. So even if you have around, say, 100, I would say if you had 10% eosinophils in the blood, if those eosinophils are not active, it would not produce any symptoms or signs or anything. Further, the blood eosinophils are non-specific. Like you said, it's higher in parasitic infections. It's higher in other EGPAs. So there's a lot of other reasons by which the blood eosinophils will be high. But if we look at the organ of damage or the organ of interest, and the eosinophils are activated there, it would mean that the eosinophils are the players in that particular phenotype. So you need to be a little bit observant and maybe 2 times or 3 times, if the phenotype is of the same nature, then the patient, you can very specifically say that this patient is going to be a eosinophilic, non-allergic asthma.
Thanks, Dr. Dasgupta. I think, yeah, another question to Dr. Rajesh.
I think there is one. I think there's one question which I can answer very comfortably. Where to do sputum eosinophil test at West Bengal? I think Madam is there sitting right in front of you.
So a little bit more pinpoint, where would the sputum eosinophil test be done in West Bengal, Calcutta, BR Singh Hospital?
Right. I think another question which has come to me is, how do you manage overlap severe asthma patient, and which biologics suit for late onset overlap patients?
Okay.
Dr. Rajesh,
Late onset patients, probably they have a non-allergic protein by and large. So I would say that most of them become candidates for anti-interleukin 5 therapy. So whether to choose mepolizumab or benralizumab, it's anyone's guess. But then, see, let me just come out of the fact that this is an AstraZeneca program. Okay. So if there are some practical things which I felt when it comes to a head-to-head mepolizumab versus benralizumab. The few things which I felt where benralizumab scores over mepolizumab would be that, the intensity of eosinophil suppression was much higher with benralizumab with mepolizumab. Mepolizumab also does an excellent job. Okay, I'm not saying that mepolizumab is in any way too inferior, but then the extent of eosinophil inflammation suppression was a bit higher with benralizumab than with mepolizumab. One, and the response occurs at a faster pace with benralizumab. By the time the patient is ready for the next dose, probably many of them are out of their oral corticosteroids. The area where I thought mepolizumab scores over benralizumab would be that there are some comorbidities where mepolizumab is actually approved for, like your eosinophilic Church-Strauss syndrome and idiopathic hypereosinophilic syndrome and all those things, where I don't think benralizumab has adequate data for it to be FDA approved right now. And the second thing is, the peculiar costing pattern in India is that upfront payment is much less with mepolizumab versus benralizumab. So that is one aspect which many of the patients actually makes many of the patients prefer mepolizumab over mepolizumab when both agents are put across together. I think I'm totally unbiased in that statement, whether GSK versus Astra versus Novartis.
Yeah, we understand that, Dr. Rajesh. I think another question which is coming up is, kindly tell us how to reduce steroids while patient is on biologics.
I don't think there is a hard and fast rule for that. It depends upon how your patient tolerates. Again, there is another point. It depends upon which biologic your patient takes. Now, if it is obalazumab, all of this have some degree of steroid sparing effect, but I feel the magnitude of steroid sparing effect is much higher with anti-interleukin 5 therapy as compared to anti-IgE therapy. One, and secondly, the clinical response and the ability to decrease systemic steroids occurs much later in the course of treatment with anti-IgE therapy than with anti-interleukin 5 therapy. So if I am starting off with an omalizumab, probably I will continue whatever dose the patient is on for around at least 2 to 3 months. And then probably, say if he is on a 30 milligram per dose of prednisolone or 20 milligram dose of prednisolone, I will try to decrease a dose of around 5 milligram every 2 to 4 weeks and just see how the patient tolerates with regard to exacerbations or the asthma control test and all those things, the rescue inhaler need, all those things. Whereas if I am using a benralizumab, probably I will venture the same thing at the end of 1 to 2 months of treatment. And again, I don't think these are hard and fast rules. I just shared with whatever I do. I think maybe yourself or Madam can also add to it.
No, you have said the correct thing. So nothing much to add.
There's another question, ma'am, for you. Is there any chance of getting EGPA on prolonged use of LTRA and Omali?
LTRA means montelukast, leukotriene receptor antagonist.
Yeah.
I don't think I will be a good person to answer this question because I haven't really used any of these in EGPA patients.
No, I think, madam, he's asking the other way around, in the sense, would usage of montelukast cause EGPA? Probably he's referring to the fact that
I see.
Our patients
the side effect
asthma,
of montelukast.
Yeah.
Okay. So in clinical practice so far, I haven't been that lucky to have seen CSS or any form of other eosinophil-driven diseases when we have used biologics. Montelukast.
Thank you,
In
Dr.
my
Rajgupta.
opinion,
Yeah.
Mhm. In my opinion, it's just a by chance because we do not see such associations in clinics. So I'm not sure if Dr. Rajesh has.
Me also know, ma'am. Probably, the general thinking among the scientific world is that initially when Montelukast came, some of those apparent asthmatics were actually patients with EGPA. So with Montelukast, when the steroids or systemic steroids were tapered, then that unmasked the another exacerbation and the unmasking of EGPA. That's the proper way scientific world looks at it, rather than leukotriene receptor antagonist like Montelukast inducing a Sturge syndrome.
Okay.
Okay, one more question, Dr. Rajesh, is when do you switch over from one biologics to another?
I think lack of response is the one. Lack of response is the one which actually makes us switch of biologicals. I have done that only in one patient as of now. With omalizumab, we wait for around 4 to 6 months before saying that it is useful or useless. I haven't actually switched from one anti-IL-5 to another as of now. So my experience with that is limited. But then with the available data that you shared with me, it gives me some confidence of switching from Nepoli to benralizumab or other way around. But as of now, most of the switches that I have done is from anti-Ig to anti-interleukin 5, and that after around 4 to 6 months of treatment. That is the time when most of the guidelines say that you have to have a global assessment of treatment effectiveness.
Yes, so
And,
I think we need
yes.
to have a solid reason for changing from one to another. What do we mean by not responding is something which have to be defined. So is it the symptoms which are persisting? Is it the eosinophils we are worried about? Is it the lung function? As of now, I take it to be 3 to 4 months of therapy, which has not caused any change in the patient's symptoms, change in the patient's lung function or patient-related outcomes as a failure of that particular agent.
Well said, ma'am. And then, to add on to this question, what should be the duration of therapy for any biologic? How do we decide on that?
This again would depend on the patient's needs, patient's pocket, family decisions. In my patient whom I had given an omalizumab, I'm just sharing a story because it's really funny at the end. So when I started off omalizumab, the patient was very happy. He was a singer, so he could sing properly and he was very, very happy. And then he was lost to follow. After 6 months, he comes back and then I tell him, what happened to you? Why didn't you come back for the omalizumab therapy? He said, oh no, don't give me omalizumab. It has caused me a lot of trouble. My symptoms have come back and my wife has died.
Oh God.
So a side effect of a biologic can also be something else and not the disease person.
I know. But that's something which I've never heard of. But yes, I think.
Yeah, so this is
it comes
just
from the
so that
patient.
people remember.
Yeah, it really remembers it. But great. I think last question from the crowd. It says, which patient type ideally suit for BT?
It's for?
BT.
Bronchial thermoplasty.
Yeah.
Oh my God. Okay, so I'll go for this first and then Rajesh can add on. When we do a bronchial thermoplasty, what we are doing is actually cutting down the muscles in the airways so that the twitchiness becomes lesser. So this indirectly means that patients who will go for bronchioplasty must have their airway inflammation controlled and then continue to have symptoms despite being controlled by some agent of the airway inflammation. So airway inflammation control, twitchiness persisting, no cells are responsible for the airway inflammation to persist, then we can offer bronchial thermoplasty to the patient.
Amazing. Dr. Rajesh.
Yeah, I think, when you don't have a choice of, it's always a debate where, if the patient has an overlapping phenotype that is amenable to biologicals as well as thermoplasty, should we go for biologicals first versus thermoplasty first? the advocates of thermoplasty put advantages across, like, it's a one-time procedure, and ultimately the long-term cost is much less than the sum total of biological therapy cost. So that's the way the proponents put it. Whereas the opponents say that it's biologicals is a much less invasive option and can be used even if the lung function is pretty bad. So that means that way. A very strange thing. Now with multiple biologicals coming, at a global market, it's maybe 5-6 multinationals playing against one multinational when it comes to biologicals versus thermoplasty. You have you have GSK, you have Novartis, you have Johnson. So the volume of evidence that's going to emanate from biologicals is going to be pretty huge. And one challenge with thermoplasty is the equipment cost. Then it's not a very steep learning curve. The learning curve is pretty okay, but then you need to have a decent lung function, all those things. So that makes bronchial thermoplasty, and it's an invasive procedure. So that makes bronchial thermoplasty slightly scary upfront for people like us. But for the trained persons, they feel that thermoplasty is superior to biological because one-time procedure, excellent results, and cumulative cost of therapy less than biologicals.
Great. I think thank you so much. I think we were about 20 minutes above the time, but it was worth the time. I really want to thank both Dr. Rajesh and ma'am for the amazing session, being patient, answering all the questions. I think thank you so much for your time. And once again, have an amazing weekend, and want to thank all the participants here, for attending the session and listening to us patiently. So thank you so much, Dr. Rajesh, and thank you so much, Dr. Dasgupta, for the amazing time.
Thank you so much. It's our thanks, I think, for Astra team as well as you. And thanks, madam, for this wonderful presentation of you.
Same to you. I'll get in touch with you and let you know more details.
Thank you, ma'am.
Okay.
Thank you, ma'am. Thank you.
Bye-bye.
Thank you, everybody.